Welcome to this explainer. Look, if you're prepping for your MBBS university exams, you already know how dense liver pathology can get. Today, we're cutting through the noise and breaking down the complex pathology of chronic liver failure and cirrhosis into high-yield, structured notes. We're going to build out some fantastic flowcharts and look at direct visual evidence so you can ace these concepts. Let's dive right in.
Here's a quick look at our agenda for today. We've got a systematic breakdown, starting with defining chronic liver failure, then the morphology of cirrhosis, clinical features, estrogen and systemic manifestations, and finally, portal hypertension classifications.
All right, Section 1, Defining Chronic Liver Failure.
Let's lock in the actual textbook definition of cirrhosis for your notes. I really want you to focus on the key phrases we've mapped out here: diffuse remodeling, parenchymal nodules, and fibrous bands. You see, this isn't just basic liver damage, it's a fundamental, structural remodeling of the liver tissue itself, complete with a variable degree of portosystemic shunting. It's a total, physical transformation of the organ.
Now watch out for this classic exam trap. Examiners love testing this. Cirrhosis and chronic liver failure are highly associated, absolutely, but they are completely not synonymous. Not all end-stage chronic liver disease is cirrhotic, and just having cirrhosis doesn't guarantee your chronic liver failure. It's very much a spectrum.
So what if your examiner asks for conditions that cause chronic liver failure without fully established cirrhosis? Well, here are your high-yield exceptions. Write these down: primary biliary cholangitis, primary sclerosing cholangitis, nodular regenerative hyperplasia, chronic schistosomiasis, and fibropolycystic liver disease. Definitely commit these to memory.
And hey, if you encounter a clinical case where the etiology of the end-stage liver disease is just entirely unknown, meaning it pops up without any clear cause, we formally call that cryptogenic cirrhosis. Moving right along to Section 2, the morphology of cirrhosis.
I want you to anchor your visual memory right here on this macroscopic image. This actually shows cirrhosis resulting from chronic viral hepatitis. Just notice that incredibly bumpy surface. You're looking directly at depressed areas of really dense, thick scarring. And those scars are separating and literally locking in those bulging, lighter-colored regenerative nodules. That normal, smooth, healthy liver capsule you're used to seeing, it's completely gone, entirely replaced by this rough, nodular terrain.
Okay, Section 3, Clinical Features and Symptoms. This number is absolutely wild, and it's highly testable. A staggering 40% of individuals with cirrhosis are completely asymptomatic until the very advanced stages of the disease. 40%! That means a massive chunk of patients have this profound structural remodeling happening inside them completely silently.
But when symptoms finally do appear, they follow a pretty deadly progression. Early on, they're incredibly nonspecific. We're talking anorexia, weight loss, maybe some general weakness. But from there, it rapidly cascades into severe advanced complications. You'll start seeing hepatic encephalopathy, terrifying bleeding esophageal varices, serious bacterial infections because the gut mucosal barrier is damaged, and ultimately, hepatocellular carcinoma.
Here's a quick, highly testable flowchart detailing a very specific and frankly miserable symptom. Step 1. Through some unclear mechanisms, persistent cholestasis occurs. Step 2. This directly leads to severe pruritus, which is just intense, agonizing itching. Step 3. The intensity is so profound that patients will literally scratch their skin raw, and that brings a huge risk of repeated, potentially life-threatening skin infections. It's a brutal cascade where a failing liver turns into a massive infectious disease risk for the skin.
That brings us to Section 4, Estrogen and Systemic Manifestations. So remember that a healthy liver is responsible for metabolizing estrogen. When it fails, here is the flowchart you need. Step 1, liver failure causes impaired estrogen metabolism. Step 2, that impairment leads directly to systemic hyperestrogenemia, basically way too much estrogen circulating in the blood. Step 3, this excess estrogen acts systemically to produce very specific vascular skin changes, specifically palmar erythema and spider angiomas.
Visually, how do these actually present? Well, palmar erythema shows up as a really distinct redness of the palms, and for your exams, the mechanism you need to recall is that it's driven by local vasodilation. Spider angiomas are a bit different.
Picture a central, pulsating, dilated arteriole on the skin with tiny vessels radiating outwards from it, literally looking like the legs of a spider. Both of these are the direct result of that hyperestrogenia pathway we just mapped out.
And this is fascinating. This illustrates how that exact same hormonal imbalance impacts male and female patients entirely differently. Both sexes can experience hypogonadism, sure, but the details matter. In males, hyperestrogenemia leads to hypogonadism and gynecomastia. But in females, the hypogonadism occurs specifically because of a disruption to the hypothalamic-pituitary axis function. It's the same underlying liver failure, but a completely different systemic presentation based on sex.